Asked to give a talk called Statistics for Dummies, and I'm assuming this is yet another slag of orthopedic surgeons, that given I'm the only orthopedic surgeon here, I'm the one who got to talk about Statistics for Dummies. So I'm going to go through this very quickly because actually a lot of this has been covered. Fundamentally, statistics are ways of analyzing data to see if groups of data or groups of subjects are different. A group against a population. This is what we do when we're doing polling or screening tests. Sometimes we use data to compare groups. This is what we do in clinical trials. There's a whole different types of variables. Continuous variables are things that like time, distance, things like that can be measured in increments. Categorical variables are things that can be done as an integer, and within categorical variables you have dichotomous variables, which is there's only two: yes, no, black, white. And then there are two types of variables. We look at the independent variable. That's the thing we can change. The dependent variable is all the other stuff we measure. Variable would be surgery versus control. Dependent variables would be outcomes, complications, and costs. Mode median, yes, you know this. A lot of you guys are going to get copies of all these talks, so I'm going to skip through a lot of this very quickly. This is your standard bell curve, a normal distribution, which essentially says that if you measure this out, 2 standard deviations of the mean is 95% of the population. That's what we're looking at when we're looking at decisions about statistical significance. Accuracy and precision. This is very low accuracy, low precision all over the place. This is very high precision, but low accuracy. Really, in statistics, what it all comes down to when we're doing a study, we start with the null hypothesis. This is done by convention. The null hypothesis says the two groups that are being tested are equivalent. In our study, we run our statistics and we get a value called P. What does P mean? P is the probability that the null hypothesis is correct, which is the opposite way that we all think about it, but this is the convention. What it really means is are they different? This idea of P equals 0.05 is just a convention. There's no magical thing that says that's what it has to be. It's just what we've all decided we're going to do. And essentially what it means is, it means that there's a 1 in 20 chance or a 5% chance are equivalent, which means a 95% chance that they're different. That's how we say the result is significant. All these tests you can use, and I won't go through them because it's boring, but basically chi-squared tests are for categorical variables. Fisher's test is for categorical variables with small numbers. T-test are means equivalent. ANOVA, if they're not equivalent, what changed to make what were the factors that led to it, and then regression and correlation, and just again a little better explained. I told you everything that you need to know about statistics. I'm going to put it into a little bit of practice. And the more useful stuff, how do you read a journal article? So when I think about it, I always read the abstract first, and I use the abstract to go, is this relevant to my practice? And the methods, the statistics, results, conclusions, starting with the abstract, because you read through that very quickly. I start out first when I'm doing a literature search. Why am I reading the study? Am I researching for an assignment? Are you researching for an assignment? So you've been given an assignment in class, researching. You're gonna do the literature search differently for that than a background study for an area of research interest. So again, here you're gonna be looking very differently at what you're looking for. But in these two cases, the first thing I'm gonna do is read the abstract and quickly go, is this useful to me? Very different than if I'm evaluating a new test, surgery, implant, drug for my patients. In this case, I'm looking at things much more critically. And the least critical way that I look at studies is if I'm preparing for a lecture or a debate, particularly a debate. Because if I'm preparing for a debate, I'm reading the abstracts to find everybody who agrees with me, the stuff that disagrees with me that I can argue with the other guy, which is usually great. So when I look at the abstract and what I do, first thing I start is what journal it is in. You've heard the idea of impact. You're looking at peer-reviewed journals, likely more impressive results than an open source. Where is it from? For a couple reasons. Look at where it's from is historically, and this is no longer true, journal articles from China were very poor quality. They're now putting out some of the best quality research going. So that's changed, but also populations are different. So a study looking, a great example would be a study, if I was looking at a study on the best treatment of TB, and I had two choices, a study from Pakistan and a study from Salt Lake City, Utah, I'm going to look at the study from Pakistan because, boy, you see a lot more TB than they see in Salt Lake City, Utah, and probably have a much better idea of the disease than the people in Salt Lake. Who are the senior authors? If you're in a field, you know who the big names are, and you tend to give them a little more credence. Whether that's valid or not, I don't know, but we all do it. The big thing is, does the abstract, does this article deal with a question that's important to me now or in the future? What type of study is it? Does the study design make sense? Results make sense? And then is the study useful? So this you can do very quickly as you read through an abstract. And I read very quickly through an abstract, and based on the abstract, I decide whether I'm going to read the whole paper or not. We've been through this, the study design and the hierarchy of evidence. I won't bother with that, other than there's a couple of things that are being added in now when we look at levels. RCT with a definitive result, an RCT with a non-definitive result, or which is the confidence intervals overlap, but this is a more important one now that we're seeing a lot more of and paying a lot more attention to. Statistical significance. But the variance is not as important. The statistical difference is not as big as the mean clinically or the minimum clinically important difference. So if you have a paper that shows with p.0001 that this is a 5-point improvement in the Oswald Street Disability Score, well, to a patient, the minimum improvement that is clinically acceptable is 15 points. So although it is statistically significant, that result is meaningless. The other is they give a little more weight to prospective study or retrospective studies with prospectively collected data. Okay, so looking at the method section, is the study population appropriate for your purpose? Is this an equivalent group of patients that you have? How were the groups selected? Randomized, what was the method of randomization? Was it done surgeon to surgeon? All of these things you need to look at. Is it prospective or retrospective? We've talked about that. Is the study powered appropriately? So if they're doing a comparative trial, particularly in a prospective trial, you have to have a power calculation. That tells you how many patients you need based on a preliminary study to not have what's called a beta error, which is you just didn't have enough patients to show significance. If they don't have a power calculation in there, you don't know if the study group was large enough. Was the duration of follow-up appropriate? A 6-month follow-up of a fusion study is not appropriate because you don't even notice pseudarthrosis at 6 months. What was the percent of follow-up? If they're only following up 30% of their patients, that's meaningless data. And crossovers in prospective studies, in randomized studies, crossovers work they're there for various reasons, but that can complicate things. And if you want a good example, just read all the stuff that came out after the spine prospective outcomes trial came out for the disc herniation trial that had a 50% crossover each way. It essentially became a meaningless study from a statistical standpoint, though there's still good data there. Statistics, basically, I generally assume the peer review process has made sure the appropriate stats were used. That may be wrong. When you're the one writing a paper, as mentioned before, get a statistician involved, and get a statistician involved before you put in the work. Because if the statistician comes back and, oh, you needed to collect this, you got to do the whole study over again. So talk to your statistician first. Results, again, I mentioned the statistical versus clinical significance. Really, know what for clinical studies, what the minimum clinically important difference is for their outcome measures, because that's what matters to patients. How precise is the data? So what is the standard deviation of the confidence intervals? If the error bars are larger than what you're measuring, it's probably not great data. Also remember that a randomized trial is powered based on its primary outcome. So saying that you have level 1 data for a secondary outcome is not valid. The best example of that historically is probably the NASCUS-2 trial, which everybody talks about, was wonderful. But remember, the only positive thing was a secondary outcome. So from a statistical standpoint, that is not level 1 data. Finally, the results in the discussion. Do the data support the conclusion? Is this new or important? If it's not, who cares? Does the paper add to your knowledge, and is it going to change what you're going to do? These are the things you want to look at when you're reading. So in conclusion, statistics are tools we use to evaluate groups. What test you use is dependent on what your question is. Read the literature in a systemized fashion to get the most out of it. And yes, that was 7 minutes, but I tried something.